So initially I was a little bummed that I saw that I was the last speaker of the day because it's been kind of a long day and everyone's tired. But then I was thinking about it, I realized that this has several strategic advantages. Firstly, if I make you all fall asleep, I can consider that a success because that is what I do for a living. Secondly, I get to go after Bushby, so I get to kind of see what a surgeon, who I would think is my most important client, thinks about our stuff. And then lastly, I get to tell you some more of the nuances and the things that Bushby didn't tell you. So one of the things that Bushby didn't tell you was that in the first iteration of the guidelines, they had one anesthesiologist, and she was so besieged with questions that this edition of the task force, they actually recruited 3 anesthesiologists. So I was very fortunate to be recruited to help with this effort, updating the guidelines. And it was a fabulous experience. I met a lot of great people and I learned a ton. But I think that the fact that they had to expand the force just goes to show that our section, which is among the longest, is really one of the most important. And it was a lot of work to go through. So that being said. Just to tell you a little bit about where we work, and my team is here, so thanks to them for being here. We are in an academic institution, so almost everything I say can be taken with a grain of salt because it is not the real world. But our mission at our academic institution is to simulate the real world, because our ultimate goal is to turn out the next generation of veterinarians that will actually leave us being able to do a spay neuter in under an hour with not a 3-inch long incision that could potentially be practice ready at the time they leave us. In addition to my secret mission, which is sensitizing them all to sort of our animal welfare mission and making sure they all know about trap, neuter, return, and all the other great stuff that we do. So our sort of spay neuter clinic that simulates the real world has a spectrum of programs. And so we obviously have different protocols for each program. So it's also important to recognize that not everything we do is the same, just like not everything you guys do is the same. So we have kind of the ultimate low volume and potentially not so high quality experience, which is that junior dog spay lab. And that's when the students all do their first dog spay. And so that's about 6 to 10 dogs in our school each week that the students are spaying. And they're intensely supervised, intensely monitored, all the bells and whistles, the dogs stay with us for days and whatnot. And then all the way up to monthly community cat clinics where we've done up to 120 cats, where we're trying to be actually efficient. We have some things in between. My staff runs a clinic on Fridays for our shelter community, which includes a lot of animal control officers and a lot of low-income pet owners. And we consider the pseudo high volume because we get through about 20 or 30 surgeries a day with 1 to 2 veterinarians. And we do that every week. And we do include students in all aspects of our program, depending on, the level of the student depends on what it is that they're doing. So that's just kind of a summary of what we do. What I want to talk about for you is highlighting some of the most important updates from the guidelines, just to bring it to your attention, going into a little bit more detail about the specific protocols, focusing on monitoring and complications, which is where I tend to get a lot of questions. I am going to talk in the tech track tomorrow, and we'll go into a lot more detail about the monitoring tomorrow in that talk. So I may speed through that on this talk. And then my goal is to leave as much time as possible for questions and discussions, because I know that you all really want to talk about, is my XYZ protocol okay? And I had this problem, what do you think? So I'm going to try to leave time for that, and I've written down some of the questions that people have been assaulting me with or asked in the last session. So hopefully we can get back to those if people need additional information. And I think some of what I'm going to say now was covered by Bushby. We've been giving a lot of talks because we're really, really excited about the guidelines, so there's a little bit of overlap, so I'll try to minimize that. Bushby talked about what patients you include at your clinic is really up to your your own particular setting. And the only thing I would add to that is that when you identify a patient as higher risk, meaning this might not be a patient who fits, what you normally do, but you're proceeding anyways because it's a life-saving emergency procedure, it's very important that somebody, either the veterinarian or a designated staff member, communicate that to the owner, that this animal is actually at higher risk than our typical patient. Here's why we're choosing to proceed today. Here's the steps we're going to take to try to make this as safe as possible for your pet. And that goes for our shelter workers that are very invested in the animals that they bring to us, as well as those animals that are privately owned. This was covered, so I'm going to completely skip that. This was also covered, but again, from an anesthesia perspective, what we really care about is the heart and the lungs. Can it survive anesthesia? That's basically all we really care about. Not exactly, but before we assess them prior to anesthesia. This is one of my soapboxes. Some of you guys have had the misfortune of listening to me before, and I tend to really drone on this, but mostly I put this in so that you know that it is absolutely fine that you're not routinely doing pre-anesthetic blood testing. So if you have an animal who you believe as a veterinarian is healthy, it is not necessary, not required by the guidelines to do pre-anesthetic blood work. We know from studies in humans and also in dogs that blood work findings do not correlate with patient morbidity as well as your findings of your physical exam. So that physical exam, assessing that animal is healthy, is the critical step. Now, the caveat is also true. If you assess that that animal has higher risk or is not healthy, and you believe that running blood work would help you manage that patient better in an anesthetic context, then by all means, go ahead and do pre-anesthetic testing. One of the things that's sort of a very point of passion for everyone working on the task force is this idea of thermoregulation and sort of holistic thermoregulation. So thinking about the animal, when you anesthetize something, you're disturbing homeostasis, and that includes the ability to maintain their own body temperature. So efforts to maintain patient body temperature to start at admission of the clinic. So that's a direct quote from the guidelines. So that's things like the temperature of the room, the insulation of the patient when you put it in the cage, like Bushby said, and all those different strategies that we all try to do to keep them warm. And these recommendations have been strengthened in this iteration of our document. We had many debates about exactly how to phrase that, and we want to be flexible because we recognize that many things that we all do work fine for us, and we don't necessarily need to stop doing that just because some 20 people said that we should, but we want to make sure that we're as safe as possible. So we really, really encourage things like heated tables, semiconductive polymer blankets, circulating warm water blankets, and warm air heating units. We really, really discourage things like blow dryers, cage dryers, and especially electric heating pads. Many of us use heated containers like hot water bottles, rice bags for us community cat people that we place in the patient's microenvironment to maintain the temperature. And that is acceptable, you just need to be really careful. So you need to make sure that it's protected context, you're not putting any of these things directly on the patient. I have seen several patients who have burns from hot water bottles. And particularly, you want to make sure that if the patient can't get away from the source of heat, either because they're still too sedate or you've covered the entire cage with hot things, you need to provide an outlet so that they can, that they're protected and insulated as we're trying to keep them warm. We talked about balanced anesthesia. Again, that's fundamental. That concept appears throughout the guidelines. So your protocol needs to make sure to deliver analgesia, loss of consciousness, muscle relaxation, and immobility, which is the definition of balanced anesthesia. I'm going to talk a little bit about protocols and some of the agents. This is kind of more the general review, mostly just to reassure you and give you some examples. When I talk to my students, I'm often having to sort of contrast for them the difference between sort of traditional anesthesia, where they have always a pre-med, they always have an IV catheter, they always have some sort of induction, usually through the IV catheter, there's always intubation, and we always maintain them on gas, which may look really different from what we do in our high volume setting, but in our high volume setting, what we do is just as acceptable and safe. So we may be doing total intramuscular anesthesia where they're just getting a single induction. And that may be our entire protocol. We may or may not be supplementing with gas. And we may or may not be intubating. I guess I'll talk on that now because that was a question from the last talk. We are not saying if you intubate all the animals in your clinic that you are doing something wrong and you need to stop. What we are saying is that if you're not intubating and things are going well for you, there's no need to change what you're doing, and you're not practicing below the standard of care. The study that Bushby referenced was a huge study by David Broadbelt out of the UK, which looked at morbidity among, they actually looked at dogs, cats, and rabbits in a huge time period, and it was published in several journals, including the British Journal of Anesthesia, which is a human journal. And basically, the bottom line is that for cats, having short procedures, the iatrogenic damage that you may do if you improperly intubate and maintain the tube, the risk of something bad happening to the cat as a complication of intubation is higher than the risk otherwise. So for cats specifically with short procedures, intubating them may increase their risk. Now, that's all of these animals over a really big time period. So certainly many of us intubate cats, but we do so properly with visualization. We're really attentive to the overdistension of the cuff and whatnot. But it is something to consider for cats. For short procedures, you don't need to intubate them, and you may actually decrease the risk to the cat by not intubating them. Question.
Do you define short?
We define short in the guidelines as 30 minutes or less, and that's a rule of thumb. So turning into the protocols, just to kind of give a general review, we're typically including analgesics, some sedative, which for us most of the time is an alpha-2 agonist, and then the anticholinergics. So most protocols are going to include an opioid in some form. That's beneficial for both sedation and for analgesia, and it helps us lower the anesthetic requirements that we need to use. And we know there's a range of drugs that include butorphanol and buprenorphine, which are our mixed agonist antagonists as well as our pure agonists. Buprenorphine I don't really find is a particularly good pre-medication for spay neuter. It doesn't contribute very much to the sedation that we need, so it's less helpful. For me in spay neuter, I think of buprenorphine more often as something I'm using for post-operative analgesia. And then the pure agonists, most often I hear of folks using morphine or hydromorphone. Recently, for us anyways, the cost of morphine has skyrocketed, so we made a transition from morphine to hydromorphone just because of the cost. And they have the adverse effects that we learned in school, such as if you give morphine to a non-painful animal, most of them will vomit. We use that a lot in ECC, respiratory depression, and constipation in chronic use. In terms of sedatives and tranquilizers, most of the time the protocols are including either acepromazine or an alpha-2 agonist, most commonly these days dexmedetomidine. And we all learned these effects in school. So acepromazine calms the patient. I don't care what the behavior says, it is anti-anxiety. It's antihistaminic, and it gives you great sedation and chemical restraint. It's also a long-lasting, non-reversible drug, which is something we need to keep into account. Has a lot of side effects, so it lowers the MAC. Some of these side effects are good for us. Lowers the MAC, that's the dose of ISO that we have to use, or SIVO. Can cause decrease in blood pressure through vasodilation, and can affect our coagulation, at least in laboratory type settings. Certainly alters thermoregulation, so some of all the efforts that we're making to keep our patients warm is because they've been given acepromazine. For the alpha-2s, similarly, we're using them to decrease the central nervous system stimulation and decrease catecholamine release and get sedation. The more worked up your patient is, the less likely the alpha-2 is to be effective. Some of you are scribbling frantically, so these slides will definitely be posted on the conference website because I realize I'm talking very fast. So the more worked up your patient is, the less likely your alpha-2 agonist is going to have the effect that you expect. So again, many times we're giving these in combination with other drugs, so that doesn't seem to be a problem. But this is one reason that, in particular for me, if I have a extremely fractious animal, I'm likely to pick a different cocktail, at least include other things in my cocktail, because the more worked up they are, the higher you increase the dose, that increases the risk of overdose and a problem in recovery. They can cause vomiting and they can cause gastric dilation, so something to be just attentive to. But the big reason that we love them in spay neuter is that they are reversible. When you combine alpha-2 agonists with any of your other agents, you get a really great feature, which is synergy, which means you can lower the dose of any of the agents that you're using and get lower of the side effects of any of the agents that you're using. You get very profound reduction in MAC, so that's why many of us are maintaining our animals on 1% of ISO or less, because we're so much lowering their requirements or relying more on our injectable protocols. They, of course, have the severe cardiovascular depressing effects, so that's why looking at the cardiorespiratory system in your physical exam is so important, because you may or may not feel comfortable using this protocol in an animal that's compromised. I always tell my students, when you give an alpha-2 agonist, you're lowering the cardiac output by half. So your question to yourself should always be, can this patient handle a 50% drop in cardiac output? And if that gives you any cause of trepidation, you might want to consider an alternative protocol. Now, there are lots of times in spay neuter where we're going back to that, this is our one chance, and we have that conversation with the owner or agent and we decide to go forward, and most of those animals do well. But it's at least worth asking yourself that question and having the conversation with the owner or agent before you proceed. And in our shop, we're in the ivory tower, mind you, but we can switch to an alternative protocol without sacrificing too much efficiency. So that's easy for us to do, and in many shelter clinics they can do that as well. The anticholinergics is a big hot topic. It seems to correlate where you went to school, whether you love these or hate these. But basically, what we're saying in the guidelines, as Bushby pointed out, is that they may be included. It's really at the veterinarian's discretion. In general, across our profession, you'll see these used less and less. I remember the days of that was our pre-med. Everybody got atropine. They got a little green dot by their name when they got their atropine. So we've evolved from there, and so I would say many fewer patients are getting these routinely, and in spay neuter, not that often. However, many clinics use them in their protocol and they're quite happy with them, so if that's the case for you, I don't think you have to worry that much about that. There are some situations where they're strictly contraindicated, and that would be pre-existing tachycardia, certain forms of cardiac disease. Your older patient, if you are doing spay neuters in geriatric patients or other anesthesia in geriatric patients, rarely do they need an anticholinergic. And if you've given an alpha-2 and then encounter a bradycardia that's freaking you out, you need to reverse the alpha-2. You do not give an anticholinergic in that context. If you decide that you can't tolerate that low heart rate at that point. And that's actually specifically discussed in the guidelines. Right now, in my clinic, glycopyrrolate is like saffron. My techs keep it in these little bottles that are like locked in a drawer. None of you guys cook. And they'll give it to me when I beg them. So we've switched to atropine, even though I don't like atropine as well for spay neuter anesthesia or any other anesthesia. So if I really ask nicely, they'll let me use some of the glyco. So that's kind of the way the world works these days. It seems like just when you get comfortable with the protocol, you have to make a change because you can't get whatever it is that you were using before. So it's good. We need to be flexible. In terms of induction agents, most people are using some kind of dissociative combination, whether it be ketamine with midazolam or diazepam or tilazol. Some folks are using propofol. Is anybody using Alfaxalone? One person. Good. I thought with 13 international folks, we might hear a little bit more about Alfaxalone. I'll touch base on it. At the moment, I think it's cost prohibitive for routine use in spay neuter, but I think it's on the frontier that we're going to be seeing this in spay neuter soon. So the dissociatives have some handy features. So they're sympathomimetic. They do provide some analgesia, and we usually give them with benzodiazepines because of the muscle relaxation. Remembering, we think about this a lot with our community cats, that these drugs are metabolized differently in dogs versus cats, so we need to be a little bit cautious with that. And these are kind of our mainstay of our combination protocols. Many clinics are using propofol. How many of you guys use propofol for your induction? So a fair hunk. We tend to do it in some of our clinics just because it's a lot less of a pain in terms of drug logging, so it's faster for my technicians. The downside is you're not getting as much analgesia as you do in a ketamine-based protocol. Some clinics keep this for that patient that does have cardiac disease where they need to switch up the protocol, or it's an older animal for dentals, things like that. So it's handy to have. Cost can be a limiting factor. Propofol 28 now has kind of helped us with the cost issue, so that's the one that has the preservative and you can keep it for a month. We don't use that in our clinic because at the vet school we go through Propofol like water, and so there's no issue with Propofol ever going bad. But at our primary care clinic, which at Tufts is located at a high school in Worcester, they keep Propofol 28 because they don't necessarily use Propofol as often as we do at the mothership. They found it to be very handy. When it first came out, we had a lot of concern about the preservative, the benzyl alcohol, causing methemoglobinemia in cats, especially with repeated doses, but they use it in all their cat dentals and they haven't had a problem. So Alfaxalone is kind of the new kid on the block. It's a newer sedative hypnotic. It's actually very similar to Propofol. This was available in Australia and Canada and Europe for a long time. It was on the market in the United States years and years and years ago, but it was marketed in kind of this funky castor oil media, and some dogs had this anaphylactic reaction to it, which was not good. So you find older veterinarians are like, oh my God, I'm terrified of this. It's because of the old vehicle when the last time this product was around. It's no longer relevant. It's a totally different formulation. It doesn't have any of the things that was with the problem. And they've been using this drug quite happily in Australia and Canada for a really long time, like 25 years. It was very slow. They had trouble finding anybody to market it for the US until Jurox, I think, is the one that has it now. I think they may be Abbott now. So there are a couple of papers looking at pediatric spay neuter protocols with Alfaxalone out of Australia, and it's got a very favorable profile for that. The really cool thing about this drug is it's basically like Propofol with a few like nerdy little differences that I'm not going to bore you with, but you can give it IM. So imagine you have Propofol, you could give IM. It's very expensive, so that's why you're not going to get it anytime soon. But where we're loving this drug, because initially I was highly suspicious. I was like, they don't use it in people. I don't want to use, I'll get you in just a second. I don't want to use it in dogs and cats. But where we're loving it is for that fractious cat with a murmur. You can combine it with your favorite opioid and Acepromazine, and you get a laterally recumbent cat in like 2 minutes. And then you can put your catheter in and do all the rest of the things that you're doing. So we've been playing around with that. My team will call upstairs and see if we have an open bottle. So I think that's coming. We just haven't seen the wide-scale use. Yes?
And it's out of the system as quickly as Propofol?
It doesn't have the same extrahepatic sites of metabolism like Propofol does, but they do seem to recover very quickly and nice. So I suppose the one time I would favor Propofol over Alfaxalone would be, pretty significant liver disease, which isn't really relevant to the spay neuter world. But yeah. Is the question up here, or are we good? The question that she had asked was whether or not Alfaxalone is as metabolized as rapidly as Propofol. Okay, so moving on to maintenance. Most of us at least are going to have gas anesthesia available to maintain. Sometimes, even though we're using an injectable protocol, we just don't get through it as fast as we think. So it's often seen as a top-off protocol. In spay neuter, I don't really think there's much of a difference between isoflurane and sevoflurane, and so we don't really think that the benefits of sevoflurane justify the cost. So either is fine. If you are doing a lot of masking or you are doing a lot of rabbits, bless you. Personally, I find the sevoflurane nice for that, but that's really not enough to make you invest in the higher cost. Okay, so in terms of analgesia, the guidelines say without any question that analgesics are absolutely required for spay neuter. So anytime you hear somebody say, well, what are they doing over there? They're not using pain meds. No, it's required. It says there liberally that it's required. Lots of options that we have. Sometimes we struggle with what's the best option for our setting, but certainly these would include NSAIDs, local anesthetics, and the opioids. For NSAIDs for dogs, labeled at this time that are injectable includes carprofen and meloxicam. For cats, meloxicam and Onsior more recently became labeled for cats for the injection. We want to be a little bit cautious, particularly if we don't know the health status of the animals. They're coming to us without a big health history. So in my understanding, the biggest chance of having a complication from an NSAID is an animal that is dehydrated. So in an animal that isn't well hydrated and you don't know their medical history, you want to be cautious. That's the reason why we always give sub-Q fluids to our community cats more than anything else, because not only are they sitting in that trap for at least 24 hours, but now we're going to give them an NSAID. So we really want to make sure that they're well hydrated. And we've even had caretakers say to us, well, those folks at Tufts do a great job with the fluids because the cats are like peeing for like a few days after, which is what we want. We want them to be flushed out and not have any NSAID toxicity. There's some discussion about when should you give the NSAID. So from a strictly analgesic mechanism perspective, it is more effective, just like anything else, to give it before the incision. In my clinic, we give it in recovery because we just don't want to run into something during surgery that would have made us think, gosh, we kind of wish we hadn't given the NSAID. Something like the animal regurgits, something like unexpected bleeding, because we know all NSAIDs affect coagulation. So we give it in recovery. We give it once we're sure that everything with surgery went fine and they're well hydrated. There are many of my colleagues who would want to box over that, but that's what we do. How long to treat is something that we struggle with as well. Many of our cats are getting a single injection. I personally believe that the perioperative injection that we give in cats is lasting several days, just based on my knowledge of cat metabolism and what we see. So in my clinic, we don't send cats home with oral NSAIDs. We do send dogs home with oral NSAIDs. Yes?
What do you give pediatric cats that really, a lot of people don't want to give?
That was the dreaded pediatric cat analgesic question. I hate that question. So we don't really have an NSAID that's licensed for kittens because we shouldn't be giving NSAIDs to kittens. We want to make sure that the kidneys are fully developed and they're not at risk for complications. So what the heck do we give them? In our clinic, when we're using a really great balanced anesthetic protocol that includes all the things we're talking about today, we often don't send them home with anything. And I used to feel really bad about that. And then I was taking care of foster kittens and coming to pick them up, the day of surgery, and they're like hanging upside down from the cage. So I think we have to not forget the surgical factor as well. So if you're the amount of pain they're experiencing is correlated to the surgical technique. So if you have minimal tissue trauma, an incision I can't even see, and the cat is doing well, I think we're okay with our perioperative protocol. We'll give them a dose of buprenorphine on the way out the door. Now that being said, there are individuals. Animals have variances in analgesic requirements just like people do. I had my wisdom teeth out. I took one Tylenol and I went back to work. I have, staff that, they're out a week on, big gun drugs. That's because everybody has a different pain tolerance. So if you have a particular animal that is painful and your standard protocol is not cutting it, you need to be available and have options to give additional analgesics if indicated. Yes?
So we do have people with 900 grams and we give them 0.1 milligram per kilogram of medicine.
So meloxicam is licensed for cats 6 months or older. So we do not recommend giving meloxicam to kittens.
What dose do you give, the 0.3 or 0.2?
The dose of meloxicam is another one of my favorite questions. So the bottle dose of meloxicam is in the United States is 0.3 milligrams per kilogram for the injectable. I don't know any anesthesiologists that think that's the dose. So I never, in capital, all caps, never give more than 0.1 mg per kg. And that's the dose that we use for peri-op. And sometimes we give less. And all that big black box that they drew around that dose says is that the labeled dose is 0.3 mg per kg once. So just like anything else in veterinary medicine, a lot of us are doing things off-label. So our lower dose is also off-label because we believe that's better. They're not going to repeat the study that they did to show that the 0.1 mg per kg dose is okay. That's why they don't change the label. So that's big bucks. Yeah.
I
I know it's fairly expensive, but do you find a lot of people who are resistant to using meloxicam, especially in younger animals, are using Serenia?
So I think the question is, you using, Serenia as an analgesic? Is that the question?
Yeah, for post-op pain, perineal pain. It's certainly been bantered
Yeah.
about a lot on the boards.
All right, so that's a great question. Wow. So her question is, do people that don't want to use meloxicam in younger animals because they don't want to harm their renal development, is it okay to use Serenia as an analgesic? So Serenia, there is a study out of Colorado that shows that Serenia, which is a substance P inhibitor, and if you guys remember anything about the pain physiology lectures that we tortured you with in vet school, substance P is one of those things that's in the sensitizing soup. So it's like an inflammatory mediator that causes pain. So Serenia does inhibit substance P as its mechanism, and it has been shown to be effective for visceral pain at the time of variectomy. I think that was a dog study. But I don't think we consider that to be adequate analgesia, because remember, in Spay Neuter, visceral pain is just a tiny fraction of the pain. We're really thinking about the tissue inflammation, the somatic pain. So I personally would not think Serenia would be adequate. I think it's fine to give. I think it's kind of cool that it may enhance your analgesia if you happen to be able to afford it and give a dose of Serenia, but I wouldn't rely on that. Yeah.
Clarify, you said that the 0.1 dose you think gives a couple of days of analgesia to a cat?
In the construct of a balanced anesthesia protocol where they're also getting ketamine, they're also getting a local block, they're also getting a pre-op opioid and potentially a post-op opioid, and I also have a surgeon that's not making a giant incision and mucking about. So then I believe that a single dose of meloxicam at 0.1 mg per kg is potentially all the cat's going to need for a spay or neuter. So moving on to local blocks, which is another controversial topic. So recently the AAFP and the I don't know why I can't say this today, the American Animal Hospital Association put together a similar task force-based set of guidelines for pain management. And one of the things that I lifted out of that, and we tried to make the Spay Neuter guidelines fall under that for analgesic management so that we don't have two standards of care for perioperative analgesia. But one of the statements I lifted out of that was that local blocks should be included for all surgical procedures unless specifically contraindicated. So I'm one of those people that used to be like, why are you doing testicular blocks? You're just removing the testicles anyways. But recently there's been a couple of papers that show it blunts the surgical response if you do the testicular block, and that's in both cats and dogs, and those are referenced in the guidelines document in the 2016 publication. So now I'm kind of like, I think it actually really helps, and I don't think it's going to hurt, and it's pretty cheap. Local anesthetics are the only thing that we do that provide complete analgesia. You're blocking those signals at the time of the stimulation from ever getting to the brain, and why not? So it's minimal risk. Potential disadvantages: lidocaine certainly doesn't last all that long. We all experience this when we go to the dentist. It may add time. So if you are doing those 3-minute cat neuters, it may not, and your patients are not painful, it may not be justified by the increased time that it's going to take. And all local anesthetics do increase bleeding. So I think all these conversations become a risk-benefit analysis for your particular setting. So you always have to take everything that I or anybody else is going to say in the context of your own clinic, because there may be tons of factors that I can't possibly throw into this talk, even though I'm talking really, really fast, that make what I say completely not helpful for you. Yes?
How long would you wait? What do you think is onset of action for lidocaine from the time you inject?
Have you ever had a lidocaine injection in yourself? So he's asking me, how long should you wait from the time you get the lidocaine injection until you do the surgery? And so I challenged him with, have you ever had a lidocaine injection? He says yes. So now we're going to get the exciting response as far as like how long he thinks it took until his face was ready for surgery.
5 minutes, depending on the dentist.
So by the time you carry that cat into the surgical suite, it should be on board. I mean, when you get a local, if you haven't had one, it's like, ow, oh. That's how fast it is, anyone who's had surgery with a local. And I'm afraid of general anesthesia. I've had lots of local anesthesia. It works, and it's fast. It does sting like a mother when they first do it, but you get past that point. And our pets are under anesthesia, so they don't have that. Yes?
Are you line blocking for space?
His question is, are we line blocking for spays? And yes, in my clinic, we do it after surgery because, you have baby surgeons and you're going to increase bleeding, and bleeding is hard for them. So we do it at the end so that we don't have that effect. Again, I think that's a personal preference for what works best for you. But certainly adding some, either along the midline before you close and potentially into the abdomen can be beneficial.
You don't think it delays healing, having the lidocaine in the incision?
There is no evidence from the human literature that lidocaine delays healing. And again, if you had a wound on your face and you went in to a plastic surgeon, what are they going to give you? Lidocaine. So do you think, I have a friend who's like phenomenally beautiful, like she should be a model and not a veterinarian. She went into the emergency room because she had a wound on her face and they blocked her whole face. I'm like, if that was going to delay wound healing on your face, they're not going to give it to you. So no, I don't buy that at all. There are studies that show that it's anti-inflammatory in certain doses, but those are in vitro studies. Those aren't in Swedish models with face wounds. Yes?
Are you mixing splash blocks with epinephrine?
The question is, do we mix our blocks with epinephrine? So we do not. So epinephrine is often done to cause vasoconstriction, sort of to limit the vasodilation. So dentists commonly do that. We don't usually do that sort of perioperatively in veterinary medicine. It doesn't. Okay, some people do, some people don't. So it's again a personal preference. If you're not having a problem, then you probably don't need to do it. So just one more thing. But the theory is beautiful. It causes vasoconstriction, so you get less vasodilation. You keep the local in the area that you're working in, and you have less bleeding. You have to be really careful if you're going to add epinephrine if you're in any sort of peripheral area because you don't want to occlude blood flow. Okay, so much for taking questions at the end. Any more local block questions before we move on? Yes?
How are you dosing like a 1 kilogram kitten with your lidocaine?
So I teach my students 1 to 2 mg per kg of lidocaine as kind of your max dose, and I do whatever volume you can do that's under that. Whatever volume is enough to block what you're trying to block. She asked the dose of lidocaine for blocks. So here are some of the blocks people have from the audience have given you this information. So the testicular block, incisional block, you can administer the drug intraperitoneal, and you can do these, well, we don't like the word, but we say splash block, where you just sort of apply it. Remember that locals don't work across intact skin. And there are, I just looked right before I got up here, between 127 and 151, the references in the new guidelines document that cover the use of local anesthetics around spay neuter. So there's a lot of references to defend any of these techniques. Okay, another one of our big issues, kind of along these lines is what do we do to send them home with? Tramadol is kind of like the drug we use when we can't think of anything better. It used to be convenient because it wasn't controlled. Now it's controlled. And a lot of people that know more about this stuff than I do don't really think that it's got good pharmacokinetics in dogs. And so at least in some dogs, it doesn't seem to be that analgesic. It has a huge dose range, which is always kind of a red flag. So the dose of tramadol in dogs is 2 to 8 mg per kg, depending on where you look. And a lot of the people say you have to dose it like every 4 hours, which none of our clients are going to do that. So in my clinic, we kind of pull this out when an NSAID is contraindicated or we think they need more, but and so we give them that. But we always say, let us know if they're not comfortable, and we'll work with you. Buprenorphine, bless you, for post-op. So this is what we're often relying, and we know that as we go to the higher end of the dose, it definitely lasts longer into the post-op period. In cats, you really shouldn't use a dose lower than 0.02 mg per kg. And you should not give regular old buprenorphine sub-Q. You don't achieve plasma concentrations that are analgesic in cats when you administer it sub-Q. So if you just, many problems with traditional buprenorphine. First of all, now they're using it to treat this opioid crisis in humans, so it's really hard for us to get, and it's really expensive. And then it may not be the best drug. You know, if you're like me with your Spay Lab dogs and they're staying overnight with you for 2 days, and you can afford it, it's great because you dose it every 8 hours. Students come in, they do their treatments, they give the buprenorphine. That's not the real world. So you guys are looking for something that goes with them, doesn't have to be redosed every 6 to 8 hours. So it's not so useful for us post-op. Many people are using the sustained release, which you can get from Zoofarm. The doses are listed on their website. I know many people in Spay Neuter that this is what they rely on, and that's great for us. Concerns that you will hear, there is one case report of a site reaction in a cat that was also at Colorado, oddly. So there's a lot of concern about this. As far as I know, that isn't documented widespread in cats. There are lots of cases in like rodents that have had injection site reactions to this drug formulation. I haven't really heard of that in dogs and cats. Anybody heard of a problem with this? Yes?
We've had a couple. I've been using it for a little while now, and when I've talked with the company, they said that the reactions were because you weren't injecting it into the sub-Q space, but intradermal. So basically what we've done is they suggest a 25 gauge needle, we use a 22, but I really just made sure to educate the staff, because they're the ones who are giving it post-op, to make sure they're getting all the way through that skin. And knock on wood, I feel like we haven't had that issue. According to the company, they usually go away within about 4 weeks or so. And the ones that I saw, they cleared up. I hadn't had them come back. So.
Excellent. So I asked if anyone in the real world has seen these injection site reactions using the sustained release buprenorphine. And she said that in her experience, and when she talked to the company, they said that happens if you don't make it into the sub-Q, like if you get stuck in the subdermal. So they use a 22 gauge needle, and she's very careful to make sure her staff is administering the injection sub-Q. She thinks that since they implemented this change, they've seen less of these injection site reactions, but she's going to be watching. The other thing she said, that when you do see these injection site reactions, they seem to resolve in 4 weeks with no sort of untoward consequences for the pet. So, you know, I think some of the concern of this could be elevated by the fact that if you have a big injection site in a tiny mouse, the consequences for the mouse are likely to be much higher than they are for dogs and cats. The bigger problem for me is this whole compounding regulations issue. And I'm not really going to get into that here, but the guidelines specifically state that whatever compounded drugs you're using, if you are using them, you must be in compliance with compounding regulations at your local, state, and federal level. Cimbidol. Is anybody using Cimbidol in their Spay Neuter clinic? No. So this, again, would be great for us. So this is a drug that you give a single dose as a pre-med, and then it lasts 24 hours. This is essentially buprenorphine. That would be perfect for us in Spay Neuter, except that it's wicked expensive. So I have been talking to a lot of people in private practice who use this a lot for their routine procedures in cats. They use it for dentals, they use it for other painful procedures. And aside from being kind of high, the cats do really well with this, and it's very good analgesia for them. So this was originally marketed by Abbott. It's now Zoetis. It is licensed for use in the cat, and you give it an hour before surgery, and you have analgesia for a day. You know, I often also wonder whether we need this. Like, do we need this level of high cats with the minimally invasive, minimally traumatic surgeries that we're having? But perhaps if you're doing a lot of, postpartum moms or more extensive procedures in your clinic, it might be useful to have from time to time. But I think it's cost prohibitive for us. All right, so I'm going to give you a few sample protocols just to kind of show how all these pieces get together. And some of these will look very similar to the ones that you use, and some of them may be different. And again, all of us are going to adapt the protocols to our setting based on what works for us, and that's fine. So in our clinic for our dog spays, we're still using butorphanol, acepromazine, and atropine. And then the students are placing a catheter, and then they're getting induced with ketamine, diazepam, and propofol. And then the analgesics we give is buprenorphine around the time of the surgery, and then as long as we have them with us afterwards, whether that's a day or 3 days. We always do blocks, and we always do an NSAID as long as the dog is a good candidate. Now, recognize that many of the things that I include is because I'm trying to teach students how to put in IV catheters. I'm trying to teach students how to do local blocks. I'm trying to teach students how to intubate dogs. So we throw in all the bells and whistles for teaching. For cats, we are trying to teach our students about multimodal and TEMA type protocols. So we always use ketamine, dexmedetomidine, buprenorphine combinations given IM, and then all the cats get meloxicam or Onsior in recovery. We are loving the dexmedetomidine butorphanol for the pediatric dog neuters and also for Zeuterin. They are doing really well. We can reverse them if they're not waking up as quick as we would like, and it's much easier on the staff. So they're not getting catheters, they're not getting intubated, and we're really liking that protocol. For our community cat clinics, we're still using TKX. And if you talk to most, I think, community cat people sort of like to stick to the traditions. So this still is the only one that has the large safety data out of Florida as far as it being safe and effective. It's also more economical than the dexmedetomidine-based protocols if you're using it for a large number of cats. They did publish out of Florida a similar protocol using dexmedetomidine, ketamine, and buprenorphine. And I haven't switched because it's a great chance to teach the students about Tilazol, and also because it's more expensive. We also give our community cats Medicam and buprenorphine. And I'm going to refer to this as Humane Alliance-esque because I feel like they're always tweaking their protocols. But the last time I looked on their website, the dogs were getting morphine and ACE, ketamine, midazolam, and Medicam and buprenorphine. And the cats were getting morphine, ketamine, dexmedetomidine, and medetomidine. And they give meloxicam and buprenorphine as well. Many people like the Tilazol, butorphanol with or without dexmedetomidine, so that can be useful as well. And then there's this one called the Quad protocol, which is used a lot in the UK. So that's ketamine, midazolam, dexmedetomidine, and buprenorphine. That actually works quite well too, as a single injection. All right, I think we covered this, to intubate or not intubate. Everybody good here? Yes.
I'm sorry. Can I just go back for a minute and
Sure.
ask you to talk about gabapentin?
Gabapentin. Her question's about gabapentin.
I've just started hearing some stuff about, people don't like tramadol anymore in dogs, and I've had a couple people, some CEs with surgeons and stuff saying that they like to use gabapentin as part of their post-op protocol. Do you?
All right, so her question is about gabapentin as a post-operative analgesic, which she says she learned from surgeons, which I find hilarious, because my surgeons, I would have to, and my upstairs surgeons, not my Spay Neuter surgeons, I'd have to hit them over the head with a board to get them to put anything on gabapentin. So gabapentin is it definitely, in my opinion, is effective for perioperative pain. There is very little in the literature for dogs and cats that support the use of gabapentin for post-op pain. There's one study out of Colorado where they did 4 limb amputations, gave them 16 pain medications, and then found that the ones with gabapentin were no different than the ones with gabapentin, which kind of shows you the problem with analgesic research is that when you're giving drugs in this setting of, well, we can't have an untreated control, right, because that's inhumane, how do you show a difference between the 5 things and the 1 enhancement? So I think that the evidence for it being analgesic as a sole agent is probably not there, but it's also a drug that has very few side effects. The biggest side effect of gabapentin is sedation, and usually they adjust to that. So for those animals where you're not comfortable with what you have to send home and you are looking for something else to add, you certainly can try gabapentin. I have a talk where I talk about chronic pain in the shelter setting, and gabapentin is one of the things that we really rely on heavily because, it's not controlled. It's something we can add in, and it's likely to help. But there's not a lot of evidence for using it in postoperative acute pain. Did that answer your question? Okay. Everybody cool? Oh, more questions. Yes.
Sorry, I just wanted to ask about the Humane Alliance protocol.
Yes.
Why they use a combination?
Why they use medetomidine and dexmedetomidine. They're going to answer the question. I know the answer, but I'd like to hear their answer.
We should have injected that. So we do tweak it an awful lot. You're right. We are tweakers for sure. But you know, we have an e-learning site that you can kind of look at when we update the drugs. We've certainly updated that. Now we're doing a TT dex, so we're doing Tilazol, Torbagesic, and dexmedetomidine. We kind of did away with the medetomidine and the dexmed because it just got ridiculous.
Yeah.
So that's what we're giving to cats, and then we're using ACE and Hydro for our pre-med for dogs. So we're not using morphine anymore for
same reason.
expensive availability.
So from the horse's mouth, I was right on dogs, wrong on the cats. My point of mentioning them was mostly to say that it's available on their website, so it's a place to go to get a start if you're looking for a protocol or changing a protocol. Yes.
And it's under the e-learning.
Under the which that always confuses everybody. So if you go to the Humane Alliance website, they have a whole section on e-learn, and it's up in like the right-hand corner, and then you have to go on medical. I mean, they have great stuff for administrative as well, and then you kind of work your way down. I often have students who give up before they get to the good stuff. So click all the way through the options, and you can get to their protocols. Yes.
Yeah, see, you use the TKX protocol?
Correct.
So, do you think that xylazine is, that much better than drugs than dexmedetomidine? And if so, why?
Okay, so his question is, why are you still using that ancient TKX protocol, and specifically xylazine compared to dexmedetomidine? Again, the reason is mostly because xylazine is cheaper, but there's another reason, which is that for dexmedetomidine, you need to be very precise in your dose. All that stuff that Bushby was talking about using the charts and making sure that you have a weight-specific dose, that is really important for dexmedetomidine because it is so potent. So if you have a little pet, the difference between 0.04 mils and 0.08 mils is really big in that little tiny pet. That's not true for xylazine. Xylazine is an old drug. It's way less potent. It's way more broad. So if you're doing community cats, and I have my friend Jocelyn from the rescue that I work with who does our inductions because she's been doing it for 10 years, and why not? I'm relying on her estimation of the weight, and so she's pretty good, but she's not a scale. So if I have somebody like that who's going to be estimating, I'm much more comfortable with xylazine. Because if I'm off 0.1 mil of xylazine, it's not going to kill the cat. If I'm off 0.1 mil of dexmedetomidine, it could be a big problem. So that's why in my clinic, I'm much more comfortable with xylazine. And there's a paper from Sheila Robertson, who's like the goddess of this, that shows that in a huge number of cats, it's safe and there's very little morbidity. And there are parts of in that context, in that situation, I think it's safer. And there are also parts of the world where they can't get dexmedetomidine, so it's a great opportunity to show the students that sometimes the old stuff is still good. So I have used xylazine in the field in Nepal. Ketamine xylazine is a great protocol if that's all you had. You get great analgesia. They wake up great. I think that in most settings for dogs, dexmedetomidine has some significant advantages these days. But again, depending on the context, it's an acceptable protocol. Yes.
To flip this a little bit, an old-timey protocol a lot of people still use is ketamine torb and dexmedetomidine versus now you're using Tilazol. Some people are using Tilazol torb and dexmedetomidine. Does anybody have any feelings one way or another?
So I think the question is ketamine versus Tilazol in the combination protocols, which I glossed over because I thought you guys wouldn't want to talk about protocols. So anywho, that's mostly personal preference. I mean, the main difference between the two drugs is that what Tilazol is teledimine and zolazepam. And ketamine, you have to bring in some other benzodiazepine. Zolazepam is really, really potent and profound and oftentimes creates that hangover that we don't always want. And the problem with reversing the zolazepam, which you can do, is that most people in the real world don't have the reversal agent. And if you reverse the zolazepam but you still have the teledimine, that's like those ketamine cats that Bushby didn't touch for 24 hours. That's the cat on PCP. So those are the differences between them. Basically, it's the same thing. You need to use less Tilazol compared to how much ketamine and diazepam you would use. And in your setting, your whatever particular recipe you're using, as long as you're happy with it, those are both equally acceptable. Another problem with Tealazole is that it tends to be a little bit finicky. Like there's all this voodoo about it, like, oh, it goes bad and stuff like that, and you have to add water to it. So you'll hear all these kinds of things. I don't know, maybe true. So for monitoring, Bushby kind of talked a little bit about this, and I'm going to talk in a lot more detail about this tomorrow. But all patients need to be monitored. We need to monitor the anesthetic depth, something with the cardiovascular system, the respiratory system, and temperature. One thing that the guidelines says that was kind of hard for us to actually put in there because we didn't really want to mess with anybody, but if you read current monitoring guidelines that are out there from the anesthesiologists and others, they say that an objective means is required. So they don't really say what an objective means is, but an easy answer for an objective means is a pulse oximeter. So something that there's no subjective interpretation required is actually necessary. So ideally, you would have a pulse oximeter at least, or some other objective means of monitoring. And that was a change this year. So these can be things like stethoscopes, esophageal stethoscopes, pulse oximeters, blood pressure monitors, and capnographs. The ACVA has great guidelines for monitoring on their website, and then in our guidelines document, it goes in excruciating detail about monitoring. And this is important because you'd like to pick up any trends that things are going south in time to do something about it. Ultimately, we want to assure that the patient is optimally anesthetized, that keeps our surgeons happy, and with minimal physiological impairment. So the definition of anesthesia is the same as the balanced anesthesia that we're talking about. That's what we're trying to kind of keep an eye on. So I'm super lucky. I have lots of students, and they love to monitor anesthesia, just like Bushby talked about. Nobody does in the real world. We do try to simulate the real world in our Friday clinic, so I tell my staff that it's everybody's job to monitor, so everybody's circulating, we're always watching, we're always checking, because you're not standing there making X's and O's. But also, if you are using electronic monitors, you want to keep in mind that they're not a panacea either, right? So this alarm fatigue is a real thing. That's when in humans, people get so sick of the beeping that they don't respond anymore. It's like that stupid pulse ox, and you don't listen to it anymore. So you need to use them responsibly, which means if it's alarming, you need to check the patient and turn the volume down a little bit so you don't get that problem. The anesthesia record, Bushby went over in detail, and this is important to at least record what was given, and so you can plan future episodes. It's obviously going to be abbreviated in our setting, and the biggest difference here is that we're not writing down the vitals every 5 minutes or ever, and that's again because by the time you wrote down a set of vitals, surgery's over, but you're still watching them continually, and if I asked you, you could tell me what they were even if you're not writing it down. So that's the one place where there's a big difference between what the ACVA says you must do and what we all do, and well, that's just life. So all these things we covered already, what to record, why we're measuring them. I'm going to skip over this just because we're going to cover it tomorrow. For the EKG, we say in the guidelines you should never use this as the single monitor that you're using because it's the electrical activity only. So it's not really telling you anything about perfusion. So it's fine if you have an EKG, it's helpful, but it's not the only one that you should have on there. And it's always good to have kind of, what is sort of where you're happy. When are you going to intervene? What's too high? What's too low? I'm going to talk a little bit about that. Blood pressure is the most important determinant of tissue. It's what we can measure that most helps us understand tissue perfusion. It's not exactly correlated, but it's the best we can do. We'd like to maintain the mean arterial blood pressure above 60, but below 140. Remember that, a lot of us will be like, oh, the pulses seem good, so blood pressure should be good. That's true that, below a minimum pressure, you're not going to be able to feel a pulse, but in general, pulse is reflecting pulse pressure and not your blood pressure, so it's not exactly true. And then we need to make sure that they're breathing and that they're well oxygenated, and a lot of our drugs can affect that. And mostly we're doing this by observing. All right, I'm going to skip ahead. So the pulse ox, it should always be 100 or close to 100. If you have a low value or an error, that usually indicates a problem with perfusion. It's very unlikely that your patient is hypoxic, I guess, if it's on 100% oxygen. If you're doing a room air or an injectable protocol, then it's highly likely that your patient is hypoxic. So take that with a grain of salt according to your context. But most of the time when our pulse ox is alarming and it's not acting like we're expecting it to, it's because our patient isn't perfusing well. So they're vasoconstricted, they're cold, something's going on where they're not as well perfused as we would like.
Can we go back to this intubating the cat thing?
Yes.
So we have I guess we're not calling them feral anymore, we're calling them community cats?
Yes. We are embracing the term community cats. We did that with our guidelines deliberately.
So I learned something this week.
Yeah. I mean, technically speaking, there are feral cats and non-feral cats that are community cats. So for me, a community cat is a cat who shows up in a trap who doesn't tell me his life story.
Okay, so we have an injectable protocol, and they have, they're pretty deep enough to do surgery on. They're vasoconstricted because of the drugs we use. They might be a little bit cold, they might be a little bit dehydrated, and yet we want them to, and they're on room air, so what do we expect them to pulse at?
Okay, so her question is, if you have a dehydrated, vasoconstricted community cat who's not intubated, what do I expect them to pulse ox at? And yes, I would say that I would not expect it to be 100% because they're not 100% oxygen and you've given an alpha-2, so they're respiratory depressed and they are vasoconstricted, so it's very tricky. That's why anesthesiologists don't like alpha-2s. It's very hard to monitor them. So, you probably have kind of what they usually are, like what you're able to monitor. So sometimes I'll say, we're just not going to use this monitor on this patient because it's getting spayed and then we're going to move on. But that's with a lot of experience, like knowing that it's okay. Most of the time, you can get it to read. So mid-90s, I would say, you should be at least having. Yeah. So it's tricky. It's hard. All right, so temperature is important. We talked about all our efforts to maintain temperature throughout the time they're with us. We would not like them to go below 96 degrees. Below this level, your anesthetic requirements are reduced and your metabolic functions can be disrupted. You want to do everything you can to minimize intraoperative heat losses, but we also have to look out for hyperthermia, especially in the post-op period. So I'm going to switch gears and start talking about complications because we haven't really touched on that lately yet. So I usually think of complications in 4 huge categories. So complications can be due to our equipment. They can be due to the drugs that we gave them. It can be due to the patient itself. Luckily in Spay Neuter, those are kind of where you see less of that. Or the procedure, which is my favorite kind of complication. Or it could be some combination of the above, right? Because it's never that simple. So for equipment, that's often something with our anesthesia machine or our breathing tube. And Bushby talked about how we're going to check our machine every day, and that's the biggest way to prevent a machine-related complication. And in the guidelines, it gives you references for where you would find directions of how to do this if you don't already. Common problems we see, stuck valves. The valves are those little white things that live under the domes and they're supposed to go up and down. If they're not going up and down, then your patient isn't able to breathe in or out. So you need to make sure that they're going up and down. Sometimes our patients are really tiny and we can't see them going up and down, so we have to give a breath and they go up. This happens to me every day. So it just happened to me I had, if you can believe it, a pig pyometra at 8 o'clock on Thursday when I was supposed to be coming here, getting ready to come here. That guy had a stuck expiratory valve, and we just banged on the machine a lot and fixed it. Issues with the Sotazorb, which in my clinic is mostly because somebody forgot to put it back or hasn't been changing it on the right schedule. Leaks, we're always on the lookout for leaks. Non-rebreathers, if you are going back and forth between the non-rebreather and the rebreather, you got to make sure that everybody knows what to do and how to check that, because that can be a big problem if someone hasn't put it in properly or the machine itself is plumbed improperly. So with intubation, we talked so much about intubation. So improper intubation is obviously a big source of complications. Problems with the cuff, kinking or disconnecting can be a problem, or the dreaded, which I see sadly too often with my students, biting through the tube is a big problem. And then also post-anesthetic airway issues, where they were fine when they were intubated, and now we've extubated them and you've got a problem. Other things, the closed pop-out valve, I always like to mention this because this is completely preventable, and it's completely unacceptable, and it's completely unexcusable. You can get this little button thing here from SurgiVet. It's like, I don't know, 25 bucks. This thing saves lives. Like, we actually track this in our teaching hospital, and we decreased the number of anesthetic arrests in our hospital just by adding these buttons. So if you don't have those and you're using machines, you should get them. And then waste gas scavenging and monitoring, which is about complications with your people more than anything else. So drug-related complications, so the big guns is your Acepromazine and your inhalant, causing a lot of vasodilation, and certainly Propofol as well. That will cause hypotension. We see tachycardia from ketamine or teletamine, especially if the patient is hypovolemic to start with. And then obviously if you give an anticholinergic, they're going to be tachycardic. And then opioids and alpha-2s cause bradycardia. Certain patients are more likely to have certain kinds of complications. So the geriatric and pediatric patients I would consider to be higher risk just in general. Last year I gave a talk about how geriatric age is a disease. So you can expect more problems with geriatric diseases, geriatric patients. Brachycephalics, I call them job security, but that's a big problem for anesthesia. There are certain sensitive breeds. And then anytime they have disease that we weren't able to recognize, we may see a problem. And then anxiety and stress on the patient.
What are some sensitive breeds?
Sensitive breeds, every breeder says that their breed is sensitive. And they recommend that you should use gas anesthesia because they're sensitive. And they recommend isoflurane because that's the latest thing. Sometimes the internet does more harm than good. But there are breeds that were, first of all, if somebody tells me that their breed or their pet is sensitive, I take that, all kidding aside, I take that seriously. Because whether or not that's true, you can guarantee that something is going to go wrong with that patient. And if it does, and I disregarded their advice, it's because they were sensitive and I didn't listen to that. So I always take that seriously, and I tell them about how I'm going to keep their patients safe and what I'm going to try to do. But that aside, there are some breeds that are sensitive. And so mostly we're talking about the MDR breeds, the ones that have the mutation. So we all know those breeds. The 4 white feet don't treat. We call them big floppies on my school. So, not that you really ever want to see these in Spay Neuter, but the Great Pyrenees and the Newfies. We do a lot of work with a group called Big Fluffy Dog Rescue. So all of them, sometimes the hounds, they're just real easy to sedate, and boxers. The boxer thing is real. So
What is the boxer?
The boxer thing, most people believe that boxers are really sensitive to Acepromazine. And there is a line of boxers, plus they all have heart disease. So there is a line of boxers out of Germany that, really, they have documented incidents of them not doing well. Most boxers can handle a low dose, but I still treat them as sensitive. So, yeah. Perception is always, the bigger part of reality. So these guys, job security, whether they're in their Halloween costumes or not, but these are a big problem. We used to not allow any brachycephalics in our clinic at all. And some clinics may do that just based on the resources that you have. If your protocol is not a good protocol for a brachycephalic and you can't alter it, then maybe that is the right choice for your clinic. We're starting to see a lot of these guys now. We have a lot of sort of these designer breeds. The good news is the mixes seem to have the hybrid vigor. So the people that have, they bought these designer puggles or whatever they are, they seem to be okay. But certainly the Bostons and the Bulldogs are the worst. All those ones are really challenging for us. So if you get one of these, pre-oxygenate them, that's essential. Always intubate them. You want a rapid IV induction, rapidly capture the airway. Make sure that you visualize the larynx when you intubate them. I get a lot of pugs referred to me upstairs for dentistry, and the history is that the RDVM, they induced them with something perfectly acceptable, they intubated them, he turned blue, they freaked out, they woke them up. And I do nothing different and it goes fine, and I think it's because they just weren't intubated. So I know a lot of techs that are really good at just throwing the tube in, and that's a point of pride for them. These are not the ones where we should do that. We need to visualize larynx and place the tube. So this, again, my favorite category. It's not my fault. So this is a surgeon-related problem or a procedure-related problem. You have hemorrhage. We see a lot of this in spay neuter, especially in a trading, not that we can't deal with, but we need to give fluids if we see bleeding, and we need to give fluids quickly, and we need to control the bleeding. The other thing that surgeons do that messes up our patients sometimes is this vagal responses. Hemorrhage is giant, on purpose, because that is the biggest problem that we see. Vagal responses is small. That's kind of like a zebra. But every once in a while, somebody grabs on something, and then all of a sudden your heart rate cuts in half, and you're just like, whoa, put that down. And that's treated with atropine. So it happens. So we teach our students to always kind of think about what your patient's blood volume is, because you need a frame of reference. Always prepare for the worst and then hope it doesn't happen. So for dogs, we use a blood volume of about 90 mils per kilo. I cut that back in cats to about 50 because they're like desert creatures. And we teach that 20% of blood volume is a safe amount to lose. And you guys all probably went to the talk this morning, so you could give this better than I am. But we replace with crystalloids. If we can't stabilize them or their PCV drops down below the critical hematocrit, which is a long formula, but for this purpose, if it's a cat and you can't get the PCV out of the teens, I would refer. If it's a dog and it's in the low 20s or lower, I would refer if you can't transfuse in your setting. And then how many people have auto transfusion sets? So a few. So I was actually shocked when I gave this, this particular point in Texas. Like half the audience had auto transfusion sets. So that may be something that's worth investing if you do a lot of big dogs, especially something that may likely to bleed. That's where you take the bleeding and you give it back to the pet. It's free. So as opposed to getting blood and things like that, that's hard for some of us to do. Or I know many clinics that have a relationship with a nearby referral center where if they needed blood, they could come and get it if they aren't able to actually ship the animal over. Or a dog, a dog bleeding a dog works too. Okay, so on a daily basis, what do I see? Lots of apnea, hypoventilation. We all see arrhythmias, lots of hypo and hyperthermia, hypo or hypertension, which you guys don't see because you're so fast you don't have time to measure the blood pressure. And then perioperative regurgitation, which is one that I really hate. I hate dealing with that. So arrhythmias, we can see bradycardia, we can see AV block, we can see bundle branch block, we can see tachycardias, and ventricular arrhythmias, which we need to treat depending on the heart rate and whether it looks really, really wide and bizarre if you have RNT. We kind of all learn this in school and then hope we don't ever see any of this stuff. So things that cause bradycardia, so being too deep, anesthetic overdose, opioids. So opioids and alpha-2 agonists cause bradycardia by increasing vagal tone. So that's fine. We can treat that with our friend atropine or glycopyrrolate. Hypothermia and hyperkalemia can cause bradycardia, and then weird things that you hope not to run into. Tachycardia can be anything. So the treatment for tachycardia is treating the underlying cause. So maybe they're too light, maybe they're too painful, maybe they're hypovolemic, maybe they're hypoxic. So we start with the easy things. We check the depth of anesthesia, we give them fluids, we adjust the analgesics, we check the temperature, and then we get down to the zebras. Hopefully it's not a pheochromocytoma, sometimes I have seen hypoglycemia though, where I have this relentless tachycardia that I just can't figure out, and then I'm like, oh, I should check the blood sugar, and it's like ridiculously low. So we can fix that as well. So you kind of work down the list. Usually, common things happen commonly. It's usually something common. So vasomotor tone is important because it regulates perfusion. So we like vasodilation because we get better perfusion, but this lowers our blood pressure. And this can be caused by a lot of the drugs that we give, like the inhalants. We don't like vasoconstriction because that impairs perfusion, but yet it maintains our blood pressure. So we're kind of always wanting the balance of these. So how do we make sure we catch these things? Well, we want to monitor within a window of safe parameters, and we want to troubleshoot when the values are out of range. So I teach my technicians, tell me if the heart rate goes up over 120. Tell me if the heart rate goes lower than 60 or 100 for cats. And then what we do depends on the situation. That may or may not be a problem for that individual animal, but at least the technician and I have an understanding about when I want to hear about it. Because for some dogs, the heart rate of 42 is completely normal and we're going to do nothing. Or if with an alpha 2 on board, we're going to do nothing. We're going to stay in the kitchen. We're going to ride it out. It's going to be fine. But in another situation, that heart rate of 42 may be really impairing cardiac output, and we need to get that up with our anticholinergic or reversing the alpha 2. So I would consider pulse ox as the must-have monitor. My techs are amazing at finding things on eBay, so you can get these little portable pulse oximeters on eBay, and they're really kind of affordable. Hypoxia, like I said, is really unlikely, but if you do have hypoxia, you need to address that right away. And then if it's not working, I mean, obviously there are settings where we know that we're going to have decreased oxygen delivery because of the alpha 2, but within the context of that, if it's something unexpected, we need to troubleshoot our patient. And capnography, usually when I ask Spay Neuter people, about half are using capnography. How many people are using capnography here in their clinic? So much less than that. So I always consider this a fancy toy that you're not going to have. So unusual, but in an intubated patient, this is excellent for detecting equipment problems. And there's studies in humans that show if you use capnography and you use pulse oximetry together, 99% of problems would be detected, which is why anesthesiologists love capnography so much. But recognizing that you're probably not likely to use it. And with these short surgery times, you're not likely to run into too many of these troubles. So red flags for me, the patient is not acting like they normally do. You haven't changed anything, but the darn thing won't stay asleep. So something's going on there that you need to troubleshoot it. Lots of respiratory effort. Usually that needs to be investigated. You need to listen to their lungs, listen to their heart, figure out what's going on. Might be an equipment problem, might be a patient problem. We need to look into that. If the pulse is hard to feel or the heart sounds far away or the pulse ox isn't working like it normally does in your setting, then that needs to be investigated. And if you're using a capnograph, we all know that a sudden drop is bad. So hypothermia, I think I mentioned this already, is not good. It increases the stress response. It impairs the coagulation. It impairs tissue perfusion. It decreases the max, so it's possible to get them really deep if they're cold. It potentiates bradycardia, and it delays recovery. So that's why we're harping on this, because it has real consequences. Hyperthermia is also not good as well. We don't want to cook them, and there are some hypermetabolic syndromes that can be associated with overheating. Some of our friends, like the greyhounds. You know, back in the day, we used to do a lot of spay neuter on greyhounds. That's thankfully going away, but they are a special category of patient. So if we identify hyperthermia, we want to rapidly identify that by monitoring the temperature, and we want to cool them and obviously turn the heat off. I just want to quickly talk about hyperthermia of the cat. So this is a thing. There's a study out of North Carolina State by Lisa Posner, one of my colleagues. We don't really know what this is. Ketamine is implicated. Opioids are implicated. Some people say hydro, but it's probably any opioid. And also intraoperative hypothermia. So the colder they are intra-op, the more likely they are to be cooked up in the recovery, which kind of makes sense because, you know, we're going to be really all in at heating them up if they're cold. But also I think it's something in the cat. Like the cat is trying to heat itself up and it's releasing inflammatory mediators. No evidence to back this up, but that seems to happen. So what to do? I used to say, oh, you know, it really doesn't have a lot of morbidity, and then Kathy Makalinsky told me a bunch of horror stories. So now I say, you know, limited morbidity, but it can be a problem if you can't get the temperature to start coming down. So we want to cool and monitor them. I always reverse all the pure agonists. I use butorphanol, so hopefully I'm not taking away all their analgesia. I give Acepromazine. I may give an NSAID if they're well hydrated and vasodilated. I may hold off on that. There's no evidence that it's a prostaglandin-mediated inflammatory response, but it makes me feel better. So if they haven't already had an NSAID, I'll often give them one, and then fluids, and get them off the hot spot. Yes? So what I do is I get something similar to what they had, and I titrate it to effect. So for this, you know, I'll start with 0.1 or 0.2. I might give like a mg per kg. He's asking me what dose of butorphanol I use to address opioid-related hyperthermia of the cat. So I'll start with 0.1 to 0.2 mg per kg of butorphanol. I'll dilute it out, and I'll give maybe about a quarter of it. and I'm taking the temperature continually during this period because there's nothing more upsetting than having a cat who's 107 and its human is there to get it. So I'm, monitoring it very vigorously while we're giving some of the butorphanol. And then once the temperature starts coming down, then we stop. If you really have a problem, like you have a super high temperature, you could give naloxone to just, do it faster, but I worry a little bit about taking away all their analgesia. So we want to monitor them until they're all back up on their feet. And I don't think we have any time left for questions, but 2 minutes for questions. Yes?
What's the base for cooling your cat?
I would probably give 0.05 mg per kg because I really want them vasodilated. That would be the dose of acepromazine I would give to a hot cat. Yes?
What's the combination that you use in the
You're asking me about bag? So she's the second person to point out that I did not give any mg per kg doses on my slides, which is done by intention, because what I find is if I tell you mg per kg and you go try it, it may not work the way it works for us, and then you'll be angry at me. So if you email me your question about specific mg per kg doses, I will help you. There is a specific recipe for bag, which is a Tufts thing, butorphanol, acepromazine, and atropine we use now as a pre-med mix. And if you email me, I'd be happy to share you that recipe if it's something you'd like to try. Yes?
Do you use any antiemetics?
His question is, do we use antiemetics? And we, in our Spay Neuter clinic, we don't routinely give all the animals antiemetics as part of our protocol, which is mostly a cost thing. Certainly we have them available, and I wouldn't hesitate to give them if I thought they were indicated, but I'm not sure how practical that is. Does anybody routinely give antiemetics to Spay Neuter patients? No, so that's not currently something we're doing on all Spay Neuter patients. Well, thank you guys. You've been a great audience.